Thank you, Dr. Beckman. That was very informative. Our next speaker, Dr. Kevin Harris, is a clinical cardiologist and echocardiographer with clinical and research interests in aortic disease and aortic dissection, valvular health disease, and heart disease in athletes. He trained at Dartmouth Hitchcock Medical Center and was previously assistant professor at Washington University School of Medicine. Dr. Harris helped create HCMC and MHI Cardiology Fellowship Program in 2011 and is the site director at Abbott-Northwestern Hospital. He is also a member of the International Registry of Acute Aortic Dissection, or IRAD. In 2005, he brought together the MHI multidisciplinary aortic dissection team, a standardized care approach for acute dissection, which was a new paradigm for the treatment of this high-risk condition, now being replicated at other centers nationally. His research, which is recognized nationally, includes over 110 scientific manuscripts. Most of all, he enjoys the complete spectrum of cardiovascular care, from prevention of disease to acute illness. He values the privilege to build relationships with patients like Megan, if I remember her mentioning earlier, and families on a continuing basis. Let's welcome Kevin Harris.
Yeah, thanks very much. So my pleasure to be back here again and see familiar faces. I just am arriving, so I don't know if this was brought up earlier, but I thought it was appropriate given the audience. So I'm not that into heavy metal, but this is the guitarist for Judas Priest who said, "I can see in my face the confusion and anguish I was feeling while I was playing Painkillers. My aorta ruptured and started to spill blood into my chest cavity." And so he finished the song. There was a tertiary hospital 4 miles away, went directly over to the hospital where a quick diagnosis was established, and he went for emergency surgery and has done well. The next individual did not do so well, and this is altogether not uncommon, unfortunately. So this is a 35-year-old male, had sudden intense chest pain, abdominal tenderness. His friends had noted this severe chest pain, and he had passed out a couple of times. He went to the emergency room and was diagnosed with food poisoning. Went home. A couple days later, went back to the ER, again with severe chest pain, had a normal chest x-ray, normal EKG. This time he was diagnosed with a viral syndrome and was sent home. He was found on his kitchen floor. His autopsy showed a type A aortic dissection and hemopericardium. So his aorta had ruptured into the pericardium, the sac around the lung. He was not well known at that time, but this is Jonathan Larson. He's the playwright for Rent. And his family has actually publicized his case for learning purposes. So there was obviously misdiagnosis of him. But even during life, he wasn't recognized, and he had some of the physical features of Marfan syndrome. So I'm going to talk to you today. Eric did a nice job of talking about the elective surgery, but I'm going to talk to you about the emergent situation and what we've done to improve the care. And we, as physicians, always learn that the mortality for an acute dissection is 1% per hour. There's certainly people that don't make it to the hospital, but there's a great paper, and this is from the 1950s, 3 authors. It goes through exactly, it's an autopsy study, what these individuals were doing at the time of their dissection. So if they were out chasing cattle or running for a streetcar or whatever, they knew exactly what they were doing. They knew their autopsy finding, their risk factors that we knew at that time. But importantly, for our purposes, the mortality came out at 1% per hour. So that number has been propagated over the years. So I'm gonna talk to you about what the progress that we've made over the years. So why does a patient with an aortic dissection die? Well, most commonly they die because the aorta ruptures, as we saw with Jonathan Larson, ruptured into the sac around the heart. And unfortunately, even in the current era, Most cases that go to autopsy have not been identified pre-mortem. So when I think about what happens to a patient that has a dissection, it starts like this. So the patient is on the far left side, is sitting at home, develops some symptoms, and in some cases the patient's not at home, right? They're playing guitar or performing, lifting weights, not uncommonly. They develop acute symptoms. It takes 1.5 hours for them to get to the emergency room. So a big part of what we do is educate patients. These are the symptoms to be alarmed about and get to the hospital. Then the patient gets to the hospital in purple there. A diagnosis is established. It often takes up to 4 hours. Okay, remember 1% per hour, right? So the diagnosis is established. So the patient may be, as Richie Faulkner was, at a tertiary care hospital. Surgery can happen or very fast, but many of our patients are outstate Minnesota, Wisconsin, they get the Dakotas, they need to be transferred to a tertiary care. That also takes time. So we've worked over the years to improve those times so we can have better outcomes. So who is at risk? I want to just kind of start here. Like, these are the patients, and this is something that has been embedded into those people that are seeing the patients that are coming in with symptoms. So anybody, probably many of the people in the audience have some of these conditions or family members that have these conditions, and that's why we're gathered today. But thoracic aortic aneurysm, and Eric described what that is, so it could be not even an aneurysm. Aneurysm is 4.5 centimeters, could be less than that in some cases. Or a family history of a thoracic aortic aneurysm or dissection. Marfan or other connective tissue disorders. Aortic valve disease. You can have a bicuspid valve or some other issue with your valve, aortic stenosis or insufficiency. But also, importantly, aortic manipulation. So you may have had a catheter in your aorta, like for an angiogram, or you've had cardiac surgery itself. You had a bypass surgery or a valve replacement. That's up to 20% of aortic dissections occur in those situations. On the bottom left is a patient of mine. I was following with a bicuspid valve, and she went 1 year to the next, and her aorta grew to almost 5 centimeters. That's a transthoracic echo. For those of you that have had echoes, that's the first view, and the aorta is not ever that prominent, except when it's high. That's highly unusual. So just to deviate from my talk, which is about the acute situation, you may be saying, well, what else? What can I do to prevent it? And we just had the aortic guidelines revised this past year. And Eric and I have spent a fair amount of time reviewing the pertinent aspects, but just some take-home points, and then I'll get back to the acute situation. The aortic guidelines have stressed that anybody that has a blood pressure at all over 130 over 80 should be treated for their blood pressure, ideally with beta blockers, which are best studied in Marfan syndrome, but we use those in other cases of aortic aneurysm, or angiotensin receptor blockers such as losartan or valsartan would be kind of a secondary class. Nobody should smoke that has an aortic aneurysm. There's actually talk in the guidelines about using statin drugs, the cholesterol drugs, if you have an aortic aneurysm. This is most pertinent for people that have atherosclerosis. So they have some blockages or buildup of plaque in other arteries. Well, we're talking about the acute symptoms. Avoidance of severe isometric exercise, fluoroquinolone antibiotics. I usually have my patients avoid those, like ciprofloxacin. We talk about family screening. And we also talk about the frequency of imaging. Usually the first image is done in 6 months, and then annually, and then we can take it from there. There's new definitions in the guidelines as to how to make measurements. There's also principles like shared decision-making, deciding together when you have surgery so you can have surgery electively, like Dr. Beckman discussed, instead of the emergency situation. So what are the acute symptoms? So usually, and I've taken care of hundreds of patients over my career with acute dissection, and I always ask them, what were the symptoms? And they almost always know that there was something seriously wrong. It's usually severe pain, often in the chest or back. It often radiates. Classic description like ripping or tearing, I don't hear that too often, but the aorta goes through your whole body, right? So the path of the dissection dictates the symptoms. So maybe in your abdomen or your leg or your neck. However, some patients don't have symptoms, and those are really the tricky ones to pick up. They just pass out, for example, and that's a significant number of patients as well. Harder to diagnose. There's a really nice series from Yale talking about weightlifting, and it's all relative for different patients, but I usually try to understand what the patient's occupation is or what they want to do. We've had a couple patients recently weightlifting, which can create significant stress. And there also are this is a really nice recommendation. It's available online for what you can do after an aortic dissection, which is like Dr. Beckman said, we can kind of talk through that at the follow-up visits, but that's a nice reference for you to have. So how do we, or the emergency room doctors that see a patient come in, how do they diagnose an aortic dissection? There might be something on exam. The video shows I don't know if the video is going to play, but it'll show the dissection involving the aortic valve and creating a leak, which is a murmur that we can hear. There can be differences in the pulses or the blood pressure between arms. The patient may be hypotensive, but again, the path of the dissection is going to determine the symptoms or the presentation that the patient is going to have. So we recently looked at that mortality for acute dissection and published this paper last year, and we found that the mortality is really no longer that 1% that has been quoted historically. We found that the overall mortality over 48 hours is 6%. For those that get treated medically, so without surgery, their mortality is 0.5% per hour. But for those that make it to surgery, which is the red curve there, the survival probability, their mortality is 0.1%. Now, a small number of patients are intended to go to surgery and unfortunately die, so that's why we put an emphasis on getting these patients treated quickly. We also even looked over the history of this organization I've been part of called IRAD, International Registry of Aortic Dissection. The medical treatment, as shown on the right, that hasn't really changed over the last 20 years or so, but the surgical mortality, as shown on the left, has continued to improve even over the last 20 years. And we've seen that in this throughout the United States, showing that showing the mortality falling over time, and in England, they've seen the same patterns as well. So why is the mortality improving so much? And in part, it's because of, I think, recognition, I think earlier diagnosis with techniques such as CAT scans, but also because of interested centers putting together aortic teams or approaches to surgery. This is just an example of what Duke did over the years when they developed an aortic program, showing a significant decrease in their mortality over the time that they had their program. We had, and I've talked about it at previous conferences, we put an effort at making the diagnosis quicker in emergency rooms and have shown a significant decrease in the time to diagnosis as well as the time to get the patient to the operating room. So this is a patient that has an aortic dissection. I don't know exactly how to work the pointer here. Oh, here we go. So that you can see the flap in the aorta right here. And as often is the case, the dissection starts just above the aortic valve and then goes all the way down. This is the descending aorta. So this patient had a multidisciplinary approach, and Dr. Beckman talked about this sort of approach. So the ascending aorta was fixed with a graft, and then the vascular surgeon came in and put in a stent graft fixing the descending aorta, and the aorta is remodeled really nicely. So that's the benefits of having this multidisciplinary team of providers that are treating acute dissections. And we have vascular surgeons work with our cardiac surgeons, and we've seen significant decrease in the mortality at our center. So it's really important, both for the elective operations and for the emergency operations, that you go and get treated at a high-volume center. This is a figure about the mortality in the acute setting, where the hospital volume and the surgeon volume make a big difference in your outcome after aortic dissection surgery. But it's also true in the elective operation as well. And in the new guidelines that have come out, there's different thresholds as far as the size of repair if you're going to go to a high volume center, or if you're going to go to your local center. So that's very important in anybody contemplating surgery. However, in the United States, in the current era, almost half of patients that receive care for their aortic dissection have it at low volume centers. And we believe that transfer to higher volume centers leads to a significant decrease in mortality. So what I've attempted to show you is that an acute aortic dissection still has a significant mortality. It's improved than what it was in the 50s because of the various techniques that I've discussed. For patients, it's important that they recognize symptoms, and if you go into the ER, you can't just get a chest x-ray or an EKG. You have to advocate for the appropriate testing, which is a chest CT in most cases. For medical teams, there should be an emphasis on the processes of care, making the diagnosis quickly, getting the patients treated quickly, getting the patients transferred to aortic centers to decrease delays and favorably impact mortality. So thanks for your attention.